and we are very pleased that you're able to join us today for this installment of our Global Connect webinars. Today, as Constance mentioned, we are really looking forward to a dialogue about how and why value-based care is being pursued across the world, and very fortunate to be joined by our esteemed panelists who are deeply involved in driving value-based care efforts, not only in our geographies that the Cleveland Clinic is operating in, but also in additional ones through partnerships like the one we have with Fabio's organization. We hope that this will be an interactive session and encourage you to submit questions through the Q&A or to just type in any comments or questions you might have into the chat. And we will take breaks periodically to address some of those questions or just to highlight developments that you'd like to cite from your part of the world. We will roughly organize this as the first half of the session we'll be talking a lot about why and what is value-based care, why do it, why pursue it. And the second half will be starting to dig into some of the how to drive this in the different markets, given the expectations that consumers or payers, the government might have. Our focus is to try to really elicit those cross-cutting themes that apply to multiple markets, and look forward to your feedback on how to do that. So I'd like to start things off with a general take on what is value-based care, how are we defining it, since there might be different definitions in different parts of the world, and why is it important for us to consider as we're in this age and moving forward. And so for that, I'd like to turn it over to Josh Snowden, our Senior Director of Global Contracting, to help us understand more about what are we seeing as in terms of value-based care themes across the world. Josh?
Thank you, Dr. Vakharia, and excited to spend the next hour with everyone. Have had the privilege to work with Fabio for the past year with our partnership, and it's been great to look at how these lessons cut across multiple different cultures and areas. I think one of the things I would just start with is healthcare is an industry that's characterized by a commitment to continuous improvement. But it's important to distinguish between activities that are value added versus models that are really value based. So a value added activity, these can be things like retail clinics, where you have an approach to healthcare delivery that can increase accessibility or convenience of services to patients. Medical records, electronic medical records. It's an important avenue to be able to increase the value of care by looking at the health system's capacity to sustainably capture information that can be used to analyze different trends and then translate those into benefits for patients and providers. But that's different from what we're talking about when we're really focused on value-based care, where you need to have the necessary infrastructures in place and incentives for all parties involved to be aligned around a shared goal of delivering high-value care to patients. Value-based care models, in order for them to work, you must be able to really drive towards a mature and self-sustaining reimbursement landscape with a focus on outcomes measurements and disease management. One of the things that we see is value-based payments have taken different manifestations across the world. You can have the use of bundled payments in the Netherlands, diagnosis-related groups in Taiwan, managed care in Switzerland. But one of the common themes across each one of these models is a shared focus on promoting accountability on the part of providers for the costs and outcomes of patient care. So in our own experience, we now have our locations from a Cleveland Clinic facility in the US and in Abu Dhabi and London. And it's been fascinating as we're looking at some of those operational challenges and lessons learned across our transition to value-based care in each one of those markets. And I'm happy over the course of today to share some of those lessons more fully.
Thanks, Josh. So you mentioned accountability for outcomes, both clinical as well as financial outcomes, and that it takes different flavors in different markets, but that's essentially the core of this transition to value as opposed to the continuous improvement model you started with. Rob, a question for you around why is this happening to us? Healthcare has been quite stable for many years in terms of people need a service and we deliver it. And we've organized ourselves quite effectively to do that. Why is this happening? And what do we have to look forward to?
Good morning, Nirav. Can you hear me okay? So this is happening to us simply because the value that we promised historically has simply not been worth the dollars that the American society is putting into healthcare. We have a lot to learn from the rest of the world. Their outcomes per capita in many ways are higher than what they are in the United States. Now, when you take an episode of care, so I'm a specialist, and let's just say we take a specialty of a cancer occurrence or a heart surgery occurrence, we do quite well. But if you try to broaden that amongst the population in terms of prevention and wellness and investing the small dollar resources to prevent large dollar expenditures, the United States is lacking. So this is happening to us because the value that we promised through these very high cost expenditures just simply isn't there. So then how do you go from moving from less value to more value? And a lot of it is in, I would say, the accounting and the alignment around incentives. So the first time that the fee-for-service payment methodology in the United States changed a bit was when the DRG, or diagnostic related group, occurred in the United States. So before the 1980s, if I put a patient in the hospital, every single day that the patient stayed in the hospital, we would charge a fee for that day in the hospital. Well, the incentive there in many ways is to keep the patient in the hospital for a long time, even if it may not be entirely indicated. The federal government in the United States, through what's called CMS, the Center for Medicare and Medicaid Services, they said, well, here's what we're going to do. We're going to create a diagnostic related group, DRG, that pays one fee. So they stay for a short amount of time, a long amount of time. In general, this is your average payment. And for the first time, the provider's incentive became aligned with the payers and also the patients, that the patient had to be well enough not to leave the hospital and come right back for an admission. On the other hand, once we achieved that level of health, we were able to get the patient out of the hospital. That was the first time. We then morphed very quickly, especially on the coasts of the United States, to health maintenance organizations, HMOs. And in some ways, unfortunately, that was a failed experiment. It was a good idea to say to let's say a primary care doctor, here's your panel of patients, and here's how much they cost last year in terms of how much expenditures they had, everything, hospitalizations, operations, prevention, everything. And we think that this next year, you should be able to manage those same patients for about the same cost over time. The problem with the HMO attempt in the late 80s, early 90s was twofold. One is the data was lacking. And we just didn't have the electronic medical record and the claims data that actually equilibrates the amount paid per claim. It wasn't robust enough to support a complex model like HMOs. Well, we're in a new day, and the electronic medical record has done a lot of things for us. One thing it has is it's digitized, so we can do a lot more data analysis and look for variations in quality, variations in cost, and the data is much improved. The other thing we've done is we've recognized the two types of risks. One is actuarial risk. Will the patient develop, let's say, a cancer diagnosis, or will they be at risk for heart disease? Versus operational risk. Okay, we're now going to treat a cancer. Can we do that efficiently and with high quality and reliability so that we can say that our unit of measure is the treatment of cancer, and in general it costs X dollars? Or is there a lot of variation? So sometimes we do a great job, sometimes we don't do such a great job, and there's this wide heterogeneity of costs. Once we are able to identify that splitting out actuarial risk, will the patient develop this condition, from operational risk, and then concentrate on the operational risk, then providers can start to get in the game, right? Then they can say, okay, I can't understand whether or not this patient necessarily will develop this condition, but once they're sent to me for that condition, I then can control the quality and the inputs to get to better health. And once you break down that unit of measure, now I think we're well underway in this evolution of accepting risk as a provider to make sure that our quality is aligned with our cost. So writ large, I think we're in a much better situation today than we were to accept risk than back in the 80s and 90s.
Thanks, Rob. So pretty sobering history for us in terms of trying to improve the value of healthcare over the last 40 years. It's not a recent development in the United States. We've had lots of wins, but also lots of lessons learned. Fabio, I'd like to bring you into this conversation. We've been working together for about a year, the Cleveland Clinic and your organization, Hospital Care in Brazil, as Brazil is on the cusp of engaging in its own journey towards value. And would love for you to give everyone an update about what you're seeing in the Brazil marketplace and how hopefully you will avoid some of the mistakes we've made in the US as you make that journey much faster and more efficiently.
Okay, so thank you so much for this opportunity here with you all. And I'm really delighted to represent my colleagues at Hospital Care. I think that what we are trying to make here or to accomplish here in Brazil is definitely to go in the direction of the triple M. So we'd like first to improve quality of care, second to improve patient experience, and third, last but not least, to reduce the total cost. And we have this assumption that when you focus on the quality of care, this is what will really drive the financial sustainability of the healthcare system. So that is our belief here in Brazil. However, as you said, it's not so easy when you start to going through the equation or the value-based equation. And we are, of course, that finding many barriers, obstacles to cross over. But just one stage early, we have seen many overall challenges. For example, in a certain way, they are interconnected and directly related, but most of them are based on cultural aspects of how the delivery care is being done today, and also about a kind of educational gap about what is what is value-based care. So the real value-based care, what is it at the end of the day? And something that we have been finding here is the entrepreneurial mindset that is necessary to drive this agenda. So based on these first two, let's say, introduction, let's say that way, we have been approaching maybe in a different way, because everything started here when I was heading a health insurance company at one of our hubs at Campinas in the countryside of Brazil. And the first thing I did was trying to find as many opportunities as I could to pilot some value-based initiatives. And along the process, we have been learning a lot. So fail fast, that was the mindset on that time. And because we have some key takeaways, important key takeaways, and then understand what Joshua and Dr. Roberts said here about the accounting piece, how to drive value, all the effort that is needed, how to align like a pay-provider approach, because which is what's the win-win equation where both can align, how to align incentives between a payer and a provider, because our health insurance has our own provider as the most important one. And of course, we have the opportunity to discover many tensions, of course, that is a proxy of the healthcare system tension as a whole. In that direction, we make important decision, and I think that we can go further, but just like in a macro perspective, we have decided to create a startup company because we would like to have someone truly 100% focused on that agenda, because it's so many obstacles and barriers that we decided to give this autonomy and independence to this startup company. And at the end, as we have been learning a lot, we have decided to set some specific goals, some value-based goals to our hubs. We have today 5 hubs at our company to incentivize them to approach value-based initiatives. So, and I think that the fundamental piece of all of these initiatives here and the strategic movement were that seeing value-based care as an approach to reduce that variation on the care side that cannot be explained by the patient profile. So I guess here we are connecting with what Dr. Robert has said between actuarial risk and the operational one. And based on that, we make important decisions here with the startup initiative to go deep dive on the operational side and go in the direction of the activities of the individual level, not on the department level, to start to comprehend all of these drivers to be successful in a value-based agenda are interconnected.
Thanks, Fabio. So far, I think we've explored in terms of the why that there's a lot of market pressures. We in healthcare, and I think this is across the world, have not necessarily lived up to our end of the bargain in terms of driving those right outcomes at a reasonable cost. And this transition to value is another attempt for us to be able to correct that. We focused a lot on the expectations of the market, but there's a couple of questions that have come through that I think are really pertinent at this point around other perspectives to consider as we make this transition. And in particular, the last couple of questions are from Melissa Lee Ng with regards to how does the transition to value-based care affect physician burnout and physician engagement? Rob, do we have a problem with physician burnout? And do you see a brighter, rosier future where if we complete this transition that Josh described, that we will have happier and more engaged physicians? And let me just broaden that to the, all caregivers who help take care of patients.
Well, in answer to your specific question, Nirav, we have a national problem with physician burnout. We have a local problem here at the Cleveland Clinic with physician burnout. I'm the president of our medical staff, and I can tell you that the majority of the conversations that we have internally around our physicians is how to improve their quality of life and indeed address the burnout. So to Melissa's question, let's just go back to fee-for-service for just a moment. There was some problems with fee-for-service in terms of physician burnout because we all become physicians to help others. And when the system was rewarding us for volume, and let's say the appropriateness of what we were doing to patients was not rewarded, and the quality outcomes were not rewarded. I think that there was a lot of, again, this cognitive dissonance that, hey, I went in this to help people, but I'm being rewarded for things that sometimes are not always aligned with the interests of the patient. So our baseline wasn't that great. I think that if we do the transition right to value-based, you're going to see a lot more excitement and engagement from the physician workforce and actually decrease of that physician burnout. So what does that look like, right versus wrong way to do this transition? The wrong way is simply just to take the fee-for-service chassis and add more responsibilities to the patient. And what does that look like? That looks like, okay, I'm in my clinic and I'm seeing my 30 patients today. And by the way, you now are responsible for 40 asynchronous messages that your panel of patients that you're responsible for has then came to your group and said, listen, I'm having a problem with this medication, or I can't get in to see this provider, et cetera. And all of a sudden your day has expanded dramatically. And those are just the patients who actually bring themselves to our attention. Then there's the 1,000 patients in your panel who are not engaged with you, but they have out of control blood sugar or their COPD is worsening. And even though those people are not seeking out care, you're now on the hook for their readmission or for their usage of the system. And it's just too much, right? We were busy as it was. All of a sudden, you have this dramatic increased burden. What does a good transition to value-based care look like? That's where we recognize that a physician is also a human being. They only have so many attention units a day and how many hours a day that they want to spend in their professional setting. And they say, how can we take away some of the menial tasks, some of the non-value added tasks? So in the United States, those things like prior authorization for a medication or a procedure that could be done more on the operational or support side and less around the top of license provider side. How can we take some of that workload away from you? How can you create a team? And Nirav, I know that you're an expert in this team-based care, where those who actually are going to do the work on the prior auth side versus the patient outreach side. Some patients are very challenging to get a hold of. And then the physician part of that can really look at the most complex patients and do a deep dive into those patients. But all of the less physician required services and tasks can be channeled over to the team. So how can we move to a team base? And then lastly, innovation. So in the past, you got paid as a physician for an E&M code, and evaluation and management. It's basically when the patient comes into the actual doctor's office. Well, what if the most important things that drive outcomes are the ability to get to the doctor's office, the ability to get your prescription filled, the ability to understand why you're getting that prescription? Those have much more impact in the value-based realm than actually just going to see the doctor. Well, unfortunately, in the fee-for-service world, you are only rewarded for seeing the patient. But when you take on more risk, you realize that all these other things that are some resource spend, like a taxi ride or a coupon for the medication or some assistance with food security, those things are what ultimately drive the highest bills in the long run. You get to become very innovative in the way that you use your resources. And so value-based care, capitated care, it allows for a tremendous amount of innovation that was stifled before because of the way the payment system was set up. So I'm very hopeful that we're going to do this transition thinking about how we innovate and bring resources to things that add to value, and less about just adding more and more work onto a provider schedule. I think that's bound to fail.
Thanks, Rob. So Josh, I'd like to pick up on Rob's comment with regards to capitation. So, and tying that back with the concept of actuarial risk versus operational risk. We often think of capitation as primarily in that actual risk bucket, right? Do we have the capabilities to manage an episode of care or total cost of care for a population? And that's pretty scary for a lot of providers to start thinking about, especially when you're guaranteed revenue for delivering services in the old model. However, can you talk a little bit about the opportunities that capitation opens up with regards to addressing operational risk? Some of the creative solutions Rob was starting to describe around team-based care and being more innovative in how care is delivered, and how providers might start to think about leveraging capitation in that way, which I don't think is often part of the conversation when we start talking about the C word.
Yeah, for certain. And I think a couple of introductory comments on that that's important to mention. When we're talking about value-based care, I think the 1-2 things we need to keep into account is that we're not just talking about extracting additional efficiencies in operations, but we're really focused about that fundamental redesign of that structure in place, driven around a patient's perspective and needs. Because in healthcare, at the end of the day, we're trying to focus on what is delivering value to a patient. So that's going to be looking at what are their health outcomes versus the amount of money spent in their care delivery. And so when we're really focused on what that fundamental restructure and redesign means from a patient perspective, there's a lot of opportunities that are afforded when you have true capitation in place that aligns those financial structures and incentives between payers and providers. And one of the things that I think is really important is for a successful implementation of the value-based care model, especially if you're talking along the lines of a capitation, is you need to have true collaboration between both providers and payers. Everyone has an asymmetry of information and their technical skills and capabilities that they bring to that partnership. Providers are able to define care pathways, synchronize services, measure adherence to those pathways, and develop infrastructures for being able to track outcomes and measure quality. On the other side, payers really have an ability to incentivize and calibrate risks and rewards for health systems. They can collaborate with providers to define criteria in terms of how are we defining which patients would be attributed or a part of that capitated plan in place, and establish appropriate benchmarks and targets to drive that performance in place. So when you have that true collaboration in place and you've got those fundamental structures, then when you're getting into the implementation side of things, being able to receive a certain funding set aside allows you as a provider to be able to best engage in those activities, synchronizing services, measuring adherence, investing in the types of resources that you need to work with those high cost, more complex patients. You know, Dr. Lorenz is talking about the difficulty of tracking some patients. There's difficulties at times with patients that from an education perspective might use the emergency department as a first pass as opposed to a last recourse if they had the opportunity to have a care navigator that explained their journey to them. Medication compliance and adherence to your medication protocols in multiple chronic disease cases can really reduce that total cost of care. So capitation affords an opportunity when you have those mutually agreed key performance indicators, those criteria defined between payers and providers, to allow that financial infrastructure on the provider standpoint to invest in what they need to do in order to be able to achieve those targets and metrics in place.
Thanks, Josh. Fabio, question for you, and it's informed by Claudio's question that was submitted online, and very much contiguous with what Josh just described. You know, historically, payers and providers, we've seen each other with some skepticism and suspicion, haven't we? But in order to succeed in value-based care, we will need to collaborate more. And it seems that that is very much underway, and getting underway in the Brazilian market. Can you talk a little bit about that shift that you're seeing from competitor to collaborator as you engage with your payers, and a couple of examples of how you're constructing value-based agreements in order to highlight that collaboration?
So that's a question. So definitely, yes. We are seeing much more collaboration right now than, for example, 5 years ago. I could say that a decade, 10 years ago, the same arguments that providers were trying to have with payers were not like sensibilizing them. And I guess that today they are very, very important in this alignment process. I think there is some observation before going more deeply on this, on the answer, that here in Brazil also, we know that the cost pressure is extremely important right now. And the way that the healthcare system is delivering care at the individual level is not more sustainable. It's just a kind of timing. And on one side, you can say that there is some people that they believe that we have more timing around and not make any movement to change. However, there is many others that are saying, hey, the timing is right now and you need to change to transform the healthcare system at this moment. So for those who believe that the time is now and we need to make some progress, there is many opportunities to collaborate. Here at Hospital Care, for example, we have been done that journey, and there is a case that I think that I can explain here in general terms, but in one of our hubs, we have engaged with one regional payer, and was around 12 to 15 months of a negotiation process. And most of the negotiation process were based on align incentives, interpretation, how to overcome problems such as how we will approach together a primary care facility, how we will approach together high complex patients, for example, how we will approach together, forget the epidemiological but operational side of the equation, because as a provider, if I am like going in the same direction as you as a payer, and I will incentivize you to penetrate, to gain market share on that specific region, I am increase my risk level. So how we will make some decisions here, hard decisions, and then the transparency comes on the table. And all of these discussions we have transformed in some specific terms in a contract. And that was the base to reach out our first accountable care model here in Brazil, and a kind of joint venture model that we have launched together one product in that specific region. And in this product, both the payer, the regional payer, and us, the regional provider, we are sharing risks. If it's upside or downside one, doesn't matter. We decided to straight our relationship and pilot this initiative. We know that will not be easy. We know that there is a lot of hurdles that we need to overcome. However, as Josh have said, as we decided to go for the collaboration, have many meetings, and a lot of discussion about common rules and put those rules in a contract, I think that both sides become very, very comfortable to go on with this entrepreneurial mindset and pilot the market with this approach. So collaboration was key here, and a team approach, and exchanging a lot of information. At the end, we as a provider were making decision on the price of the product, and they as a payer were helping us how to overcome some operational barriers to be more efficient in the care of high complexity patients. So it was a very exchange of know-how, I can tell you.
Thanks, Fabio. So, Josh, I'd like to continue Fabio's sort of line of argument there in terms of starting to build out models with payers. And you are on the phone or on Zoom meetings with payers all day long these days. Can you channel for us, especially with the payers you interact with in all these different markets around the world, what is some advice you'd give to providers who want to start moving in this direction? And I especially want us to work in a question that came through with regards to what do we do when we don't have enough data to know exactly where and when to tweak the care model in order to improve those outcomes? Any sage advice for our attendees today?
These are both excellent questions. And I think one of the things that's interesting from the Cleveland Clinic experience is we've gone through this process now where, I lived about 4 years in Abu Dhabi with Cleveland Clinic Abu Dhabi in its first years of operations, and we'll be opening up Cleveland Clinic London, the hospital, in early 2022. With each of these, we now have almost 100 years of experience that we have from a Cleveland Clinic enterprise perspective based in Ohio, but still every single market is different, and you have to be able to account for that and be able to demonstrate value de novo, but also understand what the implications are from a data standpoint. One of the things is all value-based care models purport to offer better outcomes at lower costs. But the challenge for a new market and an entrant is to be able to demonstrate potential cost savings from a new value-based model when the health system in question, by virtue of just being new to the market, doesn't have any historical data to use as a benchmark for comparisons. So you really have to be able to work towards demonstrating cost savings with appropriate assumptions that can then be used to inform how you're going to be working with those payers going forward. And I think one thing that I'd point out that's very timely and key when I'm talking about an entrant to a new market or trying to start that journey with a payer when you don't have any historical volume or data or that infrastructure in place to be able to drive that, is you have to clearly define the responsibilities in terms of engagements when contracting between payers and providers. To the point that Fabio was raising just a little bit ago, you have to really work to empower those governance models in place that will drive accountability and decision making. So for example, even prior to opening right now, with our payer conversations in London, we're really working to develop those committee structures in place and actually formalize that into our contract structures, being as detail oriented as possible, defining how we're going to drive those decision makings, what are the different KPIs, who will be responsible for sharing across certain reports and metrics, and how we will use those targets and define those targets to be able to therefore drive greater accountability. But specifically when you're talking about data and the exchange of data information between parties, this has to come early on in the process. Even if you're envisioning the work and really driving towards more of a value-based care contract between yourself as a provider and a payer, or vice versa, that capacity to share data across platforms needs to be one of the first aspects of which you're working through in that collaboration. Because from an implementation perspective, it can definitely be complicated, whether you're navigating regulations on patient privacy, HIPAA, the Health Insurance Patient Portability Act in the US, or GDPR, for example, in Europe. Addressing these challenges early on will be able to help prevent any roadblocks once you're then going to be able to be operational. So being very targeted in terms of how can we share data across? What are those reports? How are we going to measure that? What's the committee and infrastructure for that? All of those are important, even when you're looking at actually implementing changes to your contractual values based on your delivery of value 1, 2, 3 years out. You can set that timeline in terms of, we're going to establish these and have a measurement period in place. Then we'll have a year to be able to track and see how are we performing against that. And then you can have in place your formal, this is going to result in pricing modifications or the contractual rates in place. But it's really being prescriptive in terms of what are those key milestones that need to be achieved at different points, and committing to that together contractually, understanding what are the challenges and obligations to do that, and being able to overcome those.
So Rob, picking up on Josh's description and of how actually fee-for-service and value might be considered together for an organization that's making that transition, the interplay between rates and utilization. As we think about cost, we know it's a function of utilization as well as those rates or the prices that we command for our services. Can you talk a little bit about our journey as we've thought through how do we manage both parts of that equation, and any lessons we would be willing to share in terms of, and I'm going to channel Rogerio's question here. Anything we wish we had done differently if we were rewinding 10 years with today's wisdom and today's knowledge, what would we have done differently with regards to attacking that overall cost equation?
Sure. First, I just wanted to go back to Josh's point for one moment, because I saw a question on the chat that said, if you don't have the data, what should you do? So there's two answers to that in my mind. One is I was in Abu Dhabi a little bit earlier than Josh, and historically the care there was delivered through what was a grant system. They would simply grant a hospital X number of dollars to take care of X number of patients, and how the patients were taken care of, their outcomes, etc. It all was assumed that things went pretty well. But they quickly realized that there was a tremendous amount of inefficiencies. And so the first thing they adopted was the fee-for-service model. And it wasn't because they were interested in fee-for-service. They were interested in going all the way, actually, to capitation, full risk, and value-based care. But without the accounting of the unit of measure that fee-for-service allows for, whether it's the ICD-10 code, it's the CPT code, E&M code, DRG code. Without that accounting per utilization unit, you can't actually come to a higher quality capitation rate. So what they did was they accelerated the maturity 10 times faster than we did in the United States. So they went from grant model, fee-for-service model, DRG model, some episodic risk model, all the way to a variety of capitation models. But they did that like in 10 years, we've taken 50 years to do it. So one way the answer to the question was is create that, that system of maturation, but do it much faster. The other thing is there's now a international measurement of outcomes. And so out of Boston and Scandinavia, the ICHOM platform, International Consortium of Health Outcomes Management, has looked at discrete illnesses and service lines and tried to look for the most important outcomes from the patient perspective. And that's open source. It's all available online. For those of you who are developing this platform, I would say that there is an example of a benchmark and a very vigorously created, agreed upon metric. Lastly, leapfrogging technology. You know, again, if you're in a data poor environment, how can you quickly get to the data that's most impactful? And thinking about how rural areas didn't adopt telephones, but they actually leapfrogged right to cell phones. You can do that by, again, focusing on what's important for the patient through PROMs, patient recorded outcomes, and through technology that allows you to get that through, let's say, a text app or a digital app. And I think you can actually accelerate that maturation very quickly. So going back to your question around utilization, how could we have done things differently? I'll tell you, if you can marry those in the global health in terms of primary care, wellness, lifestyle, and on the specialty side that really look at an episode and marry those two entities faster, I think that that would be avoiding one of the pitfalls that we ran into here. You know, if I'm in charge of an episode, I still have to think about my outcome, the quality, the cost, etc. But in the fee-for-service world, it was always around describing that to the payer. Once we move to capitation, I still have to justify how I spend my time, how I spend my resources, and the ultimate outcome for the patient. But the stakeholders are just different. No longer is it the government or the insurer. Now it's those who run the capitation program. And they're going to be judging me still on my outcomes, probably on my total cost. And the point is that the units of measure in terms of CPT, DRG, ICD-10, and the outcomes will still be the inputs. It's just that who we report them out to, who do we calculate them to, that's going to change. And so I just encourage you to focus on the data. I think about working together on the capitation side versus the episodic care side. And then to your point, Nirav, you know, you get what you pay for. So let's just say that we've decided that we're going to run an episode for hip replacement, right? What you're going to get, I think, is improvement in the outcomes of hip replacement, decreased cost when it comes to the cost of a hip replacement, and the patient's outcomes will be more aligned with the payers and the providers. But let's think about something different. Let's think about paying for osteoarthritis of the hip, and that the outcome is really to live pain-free, fully functional, and not be limited by the disease process. Whoa, then you start to get all kinds of innovation, right? What if the best treatment for that is not a hip replacement, but what if it's an alternative therapy that has actually improved outcomes over hip replacement and maybe a decreased cost? So the unit of measure is important as far as the innovation that providers are allowed to do when it comes to getting patients healthy. So in answer to your question, concentrate on what you're incentivizing, on what the definition of the outcome is, and that will then drive that innovation to say, okay, you're not really going to focus on the exact inputs. All you want is a great outcome. In that case, I've got a great idea for improving the outcome to that patient. You and I, the payer and the provider, will share in some of the savings, but the ultimate winner is the patient, because they got to health faster at a lower cost with better outcomes. So that's the answer.
Thank you, Rob. So we're going to turn now to some of the questions that have been submitted, and thank you to the audience because there are numerous here, and I hope we'll get through as many as we can. Fabio, one for you from a fellow physician in Brazil who is just being very straightforward and saying, look, I'm happy in volume-based care. How can you make this more palatable for me to transition to value-based care? Will I be just as financially successful in this new model? How are you addressing this with the physicians you're engaging around these new value-based models you're building in hospital care?
Okay, so that's a great question. But just like I would like just 1 minute to come back to this point that Dr. Robert said about this more accounting perspective. So we have been developing a methodology of care design. So of course, this is a kind of entrepreneurial methodology. So we are learning a lot, many innovations, what we are trying to accomplish. And I think that one great learning here that is going directly to the value equation is that as we are directing our efforts to the activity-based level, we are discovering that some fixed costs definitely are not fixed. They are variable. And if they are variable, we can manage them from a managerial perspective. And if we can manage them, we can create more efficiency. And then we are forecasting some drivers that we could decrease the total cost of care for 2 specific episodes that we are working with. So that, I think that is a very good point to share here with our audience. But connecting this point with the physician question, the physician engagement is a critical point here that we have learned a lot, and it's a critical point in our methodology. Because without this engagement, without experts, for example, their know-how, for us today, it's almost impossible to drive this innovation at the patient level, at the bedside level. And one thing that we are working right now is how this financial allocation of the resources will connect the physician that is working with us, with the hospital, with the outcome, and with the final pricing points that we will negotiate with a payer. So overall, it's critical, and I really believe that as much physician as possible engage in the care process redesign, the care delivery redesign, will be easier to make this transformation from the fee-for-service from a value-based one. And also, if they are not engaged in the process, someone else will make this decision and probably will not be so well aligned with their expectancy. So that is one very important point why on our methodology here that we are developing on this startup, we are engaging since the beginning with the champions. We call here the champions, and they are part of this equation. So they are driving the innovation with us.
Thanks, Fabio. We also have a question from Reggie-Ann that Josh, hoping you can take a stab at with regards to pharmaceutical spend. So it's a high and growing share of that overall expense. In your work with contracting in different markets, how are pharmaceutical companies coming to the table? Are there any creative or sort of innovative approaches to partnership with pharmaceutical companies that you've seen that you would highlight?
Yeah, it's a great question. And I'll draw upon a little bit of my experiences in CCAD in Abu Dhabi as we were actually navigating a challenge around reducing cost for patient populations with the use of branded pharmaceuticals. So of course, there's multiple different considerations from a provider standpoint that you have to account for, whether you have bioefficacy, bioequivalence between a branded and a generic drug. How are you measuring that between payers and providers? And so what we really worked to develop, and this was actually in collaboration, not only with us as a provider, but with the Department of Health. So from a regulatory standpoint, with payers in the marketplace, as we were looking at developing reference reimbursement rates for generic medications, being able to track medical utilizations on that to help inform inventory decisions and clinical reviews, especially around as we were measuring with the introduction of new drugs. How do we go about the process of really demonstrating that that is value added and not something that is just from a price perspective, a brand new technology that we have to introduce because it's out there in the marketplace. So really developing those structures and criteria in place allowed us to introduce new types of drugs that really did demonstrate a higher efficacy in treating certain populations, whether that be the introduction of new hepatitis C medications, for example, that was for the first time introduced into the region to be able to treat those complex cases for patients that previously might have had to travel overseas to receive that because there wasn't that infrastructure in place to make sure that those would be approved and from a regulatory standpoint, as well as reimbursed from a financial perspective. I think when I look at that experience and I translate that to different marketplaces, what's key is really establishing both KPIs around what are we trying to measure from the role of pharmaceuticals in terms of the overall healthcare cost and spend, but then also really establishing those channels for clinical to clinical conversation and operationally too, as we work through introductions of new pharmaceuticals or measuring and monitoring adherence to pharmaceuticals, measuring bioefficacy changes between branded and generic drugs, and really using that as criteria and metrics to be able to ensure that we're doing things that are right for patients, but those are also being done at the best value. So you're measuring what is the incremental benefit from an outcome perspective versus what could be the total costs associated with that. And when you have that right discipline and structure in place, many times you might determine that it is very appropriate to reimburse for that. But in other instances, when you follow that same criteria, that's when you can determine that this is something that we need to be better partners around in terms of choosing a lower cost drug alternative.
Thanks, Josh. So you started to outline a framework there for how will you know if you're driving success around more value conscious prescribing. I'd like to broaden that, and this is in order to tie in a couple of questions that have come in, one from Felipe and another from Daniela, which essentially the question is, how will we know if we're driving value? And so this is going to be a question for all three of you. It'll be our last question that we answer. But how do we know when we get there? And in particular, what kinds of benchmarking do we need to be mindful of as we engage in this journey to ensure that we can build the case for the fact that we are driving greater value on behalf of our patients? So I'm hoping you can combine those questions, and would anyone like to start?
I'm the only one not on mute, so I guess I'll start. I think the short answer to your question, Nirav, is that you see all the tremendous inefficiencies and waste that are in the system today. And there are many metrics around the waste, whether it be excess utilization, unfilled medication compliance, inappropriate utilization of procedures, hospitalization, you name it. There's some pretty well-established benchmarks in the literature. And you start to align the incentives between the payer, the provider, and most importantly, the patient. And all of that waste starts to get absorbed by the value add. The real question is, how do you measure that, right? And so we talked about patient-reported outcomes. I think we also need to focus on this total cost of care concept that in the old days, it was all around price, and people have recognized that sometimes it's worth the additional higher cost of medication or an implant or otherwise if the total cost over a more extended period actually has greater value. Now, what are some of the frictions there? Well, in the United States, unfortunately, we have a churn between insurance plans, that a patient might have this insurance plan today and a different one tomorrow. And the problem is who's going to invest in the hard things of education, medication compliance, wellness programs, lifestyle modification. These are long-term investments that have significant ROIs, but it takes a significant amount of time. I believe there actually lies a business opportunity that if a plan, an employer, invests quite a bit in somebody's health, and then that patient, for whatever reason, changes employers or changes carriers, insurance carriers, that investment in their health may be able to be transferred to whoever's going to catch them with their next employment or next insurance program. Now, on the bad side of that, that's a recipe against pre-existing conditions, which is an ugly negative side. But what about those people who actually undergo modifications to their lifestyle to decrease their cost long term? I think that there's a win-win there. I think that there's a way to reward payers and employers who take great care of patients and patients who take great care of themselves to actually have incentivization around those, whether it be from the employer side. So the short answer to your question is look for the waste, look for the inefficiencies, get all the interests aligned, keep the patient as the focus of what we're doing, and I think that this will be successful in the long run.
Great, thank you, Rob. Josh or Fabio, any last comments before we turn it back over to Constance?
I'll chime in just real quickly with a couple points, and then I'll leave it with Fabio as we talk about how this can be translated for the Brazilian market. But just a couple of points building on what Dr. Lorenz is talking about. New payment delivery models, these aren't going to be developed overnight. Value is really, it's a journey. It's not just a destination, and it does require thoughtful planning and collaboration to achieve successful execution. I think one of the things that's paramount is you can look at your process structural, your quality, and your cost price, different types of key performance indicators and metrics. And at the end of the day, it all comes down to having the right type of structure in place that's rooted in outcomes that matter to patients. So whether you're engaged in activities around value stream mapping or trying to be able to remove all that unnecessary waste and utilization, implementing those right process structural metrics will in themselves help lead to greater cost and price efficiencies, and will be able to help lead to greater outcomes and quality when you're setting that up in the right infrastructure. So have that singular focus in place, know that it's going to be a journey, not going to be something that's going to happen overnight. And you do need to be rooted in those outcomes that matter most to patients, because that at the end of the day is value. We're determining what is that value to the patient. How are they understanding their outcomes based on the amount of money spent for their care delivery?
And hopefully that journey doesn't take 40 or 50 years, right? Fabio, last word.
Yes, and just to make additional points here and give more perspective from Brazil, that some important key takeaways from our side here on how to implement value-based agenda. I think that one important key takeaway from our side is that we need to focus on the big rockets. It's a waste of time if we go so granular details right now. It's a kind of losing the track. So I guess that thinking about the big rockets and since the beginning on the big opportunities, big costs, and also which is the most important medical conditions to focus on that. I think that is a great starting point. And if you have capability, start to build in a repository of data. For example, as we have our own health insurance and our own provider at one of our hubs, we have developed populational KPIs very aligned with the CMS accountable care KPIs. And for example, some of those we can track and compare ourselves with that dashboard that anyone can publicly access, the CMS. This is a way to go, to compare, to have some kind of benchmark. But I think that on the end is more about, at least here on the maturity level that the value agenda is here right now in Brazil, is more about choosing the correct partners, collaborate as many as possible, learning from each other, turn to your organization and know which is the better way to go. I mean, for example, experts inside the organization, business people inside the organization, financial people, ask help and try to overcome some educational barriers and gap, and make efforts, because it's, as everybody said here, is a journey. It's not something that will turn around from day one to day two. So we need time. It's not a monthly agenda. This is a multi-year agenda, and to be sustainable will take a little bit longer than only like that short-term outcomes that could be mistakenly expected. So
Thank you,
we are
Fabio.
very here in Brazil, and thank you so much for all the learnings from Cleveland Clinic. Thank you.
Thank you, Fabio. So with that, we'll wrap things up. Constance, if you don't mind informing the audience about any ability to stay in touch, as well as how to access the recording.
Thank you, Dr. Vakharia, and thank you so much for our clinical and hospital care panelists for sharing your insights and lessons learned. And to our audience, thank you so much for joining us and all your insightful questions, which make really incredible discussions. Just a quick reminder before we close out is that there will be a brief survey once you leave Zoom, and we're truly looking forward to hearing your candid thoughts and suggestions for our future webinars. Thank you so much, everyone, and we'll see you next time.